Welcome to PEM Chatt. This is a peer-to-peer educational podcast about pediatric emergency medicine for the advanced practice provider. My name is Tony Dobson. I am a family and emergency nurse practitioner in Chattanooga, Tennessee, and I will be your host. I'm excited to be here today with Dr. Jordan Foutch. Today in PEM Chat, we're actually going to be talking about the approach to a limping child, which could be a lot of things to a lot of different kids. It's a pretty common complaint. I'm sure they see it a ton at primary care offices, but we see our fair share in the emergency department. So we're going to talk about how to work that up today and what that looks like and what our approach should be. But before we get started, tell me about you. Who are you? What do you do?
Yeah. Hey, thanks for having me, Tony. My name is Jordan Foutch. I'm one of the PEM docs at Erlanger in Chattanooga. I am just at a year out of fellowship now. I did my residency here in pediatrics at UT College of Medicine at Erlanger, and then I did my fellowship at MUSC in Charleston. And now this is home for us. My wife and I both consider this area home, and we've been really, really happy to be back.
Yes, and your wife is precious. I love her. And we're happy to have you guys back. You have me over to your house today, and you have this very cool office/man cave thing going on.
Yeah. I went with the dark, cozy vibes.
Yeah, I love it.
Yeah.
Almost black paint. It's really cool. I love it.
Yeah.
I can see you gaming in here at night.
I definitely game in here at night a lot.
When you're on night shift and Jessica's on day shift.
Exactly.
Sure. All right. Awesome. Well, our goal today is to really kind of drill down on septic joint. But when you see these patients, they don't come in and say, I have a septic joint, right? They come in with pain or limping or whatever that might be. So what we want to kind of start with is how do we focus our differential? We got a kid that comes in with a limp. Where do we start?
Yeah. So to me, this is a really common complaint. Speaking from us, we see it all the time in the emergency department. And I'm sure it's seen all the time at doctors' offices and urgent cares. But in my mind, the first distinction you have to make, is there any concern for a bacterial infection? And really, you can really boil that down to, in my mind, to is there a limp plus a fever? If the kid's vital signs are okay and they're not overtly really sick or septic, if they have a limp and a fever, that's your first jumping off point. I can't really see getting around a workup, including inflammatory markers and white blood cell count when you've got those two symptoms to start. So that's really kind of my first decision point for these kids with these limps.
Yeah. And, getting a good history, right? Like what makes sense for this patient. So kind of drilling down, was there trauma in the past? And then you mentioned earlier when we were kind of talking this over, age.
Yeah. So outside of fever, when I say fever and limp, that's all age ranges. That's an all comers. That's you do not need to miss a septic joint. But for limp, outside of that, and even sometimes with fevers, thinking through your differential, I think that one thing that makes pediatrics tough is that there are so many different potential pediatric specific diseases that are for specific age ranges. Say, for example, like for say a skiffy, you expect that to be usually an obese young teenager. Like that's the presenting age, that's that presenting kind of clinical pattern, as opposed to say if transient synovitis or something that may have a fever, usually in a little bit younger kid. You don't see that quite so often with older kids and teenagers.
Yeah.
So I think there's a lot of stuff where you can really, really kind of hone down your diagnosis by putting kids into boxes based off what kind of age group they are: toddlers, young children, school-age children, young teenagers, older teenagers.
Yeah. And then remembering also that the story has to make sense for the presentation. So particularly in a kid that can't express what happened or can't recount the story, if the story doesn't make sense, we have to consider NAT or non-accidental trauma. That's kind of always on the back of our mind when we're examining kids. So when we examine a child that presents with this, how would you go about a physical exam, and what tricks and tips might you have to get through an exam, maybe like on a difficult kid?
Yeah, that's going to be tough. A lot of the times these kids they start unhappy, and it's going to be really tough to win them over or to get them to cooperate with physical exam. And sometimes there are a few tricks that you can sometimes use to get a kid to try to walk specifically. But a lot of times your need to get a good physical exam outweighs this child's discomfort, to put it bluntly. Sometimes you have to be what seems like a little bit mean to a kid to get a full physical exam, and it's not really great. We don't like to have to do that, but you need to for their own good, to make sure you're not missing something big, bad, scary. In that, there's for a lot of these potential like red flag, do not miss diagnoses, if you're really concerned, there's some subtle hints on physical exam that you only see if you get a full physical exam. So there's a lot of looking for gluteal creases, a lot of checking genitalia in pediatrics, specifically for some of these mimickers of a potential septic joint or its own surgical emergency if it's a torsion or something like that. It's really something where you gotta kind of put your boots on and do the exam, even though it may be uncomfortable or may not be, maybe pretty time consuming sometimes. To get the full picture, you really gotta undress these kids, range them at each of the potential joints infected, to put the whole clinical picture together.
Yeah, looking at all the skin. I think this was something I really learned when I moved from the adult ER to the children's ER, because we certainly aren't in the habit of undressing every human being in the adult side, or even ranging all of their joints for that matter. But really looking at a kid from head to toe, like every single inch of their skin, ranging every single joint, remembering that one thing can mean another thing, and if you don't look at it, you missed it. So yeah, super important with this. The first few I assessed at children's, I remember walking back and my attending saying, well, did you range the hip? And I'm like, they told me it was the knee. Or did you look at the skin? And I was like, I didn't do that. So yeah, really learning to back to that basics, head to toe, really good physical exam. Do you like to examine kids laying in the bed, laying on the mom, sitting in a lap? What do you like?
So talking about a limp specifically, I think that it varies based off what the chief complaint is. But if you're really worried about a limp, I think you're going to have to do a couple of those things. I like to do a lot of the exam. If they'll lay in the bed by themselves, you can do a lot of the ranging of the hip and knee and ankle and whatever joint you think may be involved, but you can range them a lot better if they're laying there. Sometimes, depending on how aggressive the child is, you can get some of that exam while they're hanging out with mom, but it's definitely not going to be quite as accurate. But the other thing that you're going to have to do is walk these kids, which can be really tough sometimes. Back to having to be kind of mean to children sometimes. One way to really see if they'll walk is if they really don't like you. If you have the kid and you're examining them, you put them down and see if they'll walk from you to mom. And a lot of times how much they dislike you outweighs how much they don't want to walk, and so you can see if they truly do have a limp, they'll hobble away from you, or if they really can't walk, you can figure that out.
Yeah, I've coined that the flamingo test.
Yeah. Sometimes, it's the flamingo or the crisscross applesauce if they bring both up, or sometimes they just straight out. Down. Yeah, I will not touch the scrum. Yeah,
I do that all the time when I think it's a toddler's fracture, because they won't put the leg down. They will hold it up, and that was something I learned at children's.
And they can have and just palpation doesn't do it sometimes for those. Like, they can be so non-tender focally anywhere on the exam, but they just absolutely will not walk for some of those kids. It's pretty interesting.
And a kid that won't use an extremity is never normal, right?
No.
And those are kids that don't go home. So we really want to look at that. So, all right. So I was just reading this morning things that can kind of cue us into the more infectious processes, really exquisite pain. They are screaming and yelling, or won't let you touch something. Fever, obviously, we talked about that. tenderness of the joint or decreased range of motion. And I have found that to be very pronounced with a septic joint. They will guard it,
Yes.
lock it up. They
Yeah.
will not range it.
You know, it's just like anything else. It kind of depends on what the disease process, where it is in the process. So if it's really set up and it's getting to the point to where it's already stretching that capsule with that pus and fluid, and it's putting that strain on the joint, those are the kids who are going to be doing everything they can to maximize their joint space. So those are the ones that they're doing what I call the I have a septic hip move, where they're just laying in bed with their with the affected leg externally rotated and abducted with the knee flexed. Like they just lay there, and that's the position of comfort, because that's what opens up that joint space the most.
Yeah.
Whereas it can sometimes be subtle, because it's just like it's the spectrum of disease. Like if you're catching it early enough, it could just be fever and some pain, maybe with or without decreased range of motion yet. And so if you have even minimal symptoms, that's why I'm just going to go ahead and check some screening labs.
Yeah. So I'm going to give you a hypothetical patient here. So we have a kid that comes in. He's not ill appearing, has not had a fever, but he's got leg pain, like he won't walk. Definitely when you do your exam, he won't bear weight. You don't see anything that looks red swollen, but he definitely will not bear weight on that leg. Parents are worried because, this happens suddenly, and they're like, hey, this is not normal. We don't know of any trauma. So how do we approach this? What's our workup going to look like for this kid?
Yeah, I think that it really is going to depend on what you find in the history and the physical exam to start in association with any current vital sign abnormalities. Like if they come in the door with that story and the fever, of course we're still going to do the physical exam and
Let's say for this kid, no fever.
Yeah, no
this
fever.
This is a no fever kid, but he had a URI this week. He's had a runny nose, cough, congestion, but no trauma, no fever.
Yeah, absolutely. So from there, I'm going to kind of differentiate things based on those age boxes we were talking about. Like if you're limping and you're, say, a toddler, like if you're a 1 to 3 year old with maybe some URI symptoms, but there's one specific leg that you won't range, I'm going to try to find the source, which is sometimes difficult. So I'm going to range both of your lower extremities completely and search for any focal tenderness. But if you're a 12-year-old high BMI kid, I'm going to be doing those same things, but really focusing on the hip more. Whereas if you just recently had a URI and you're, say, a 5-year-old, like, kind of in that range, and there's really nothing focal on exam, if you actively have a fever, I'm probably still going to get labs on you, right,
okay,
while we wait. But if you won't walk in the ED and you're febrile, we're gonna be doing some investigating, and by that I mean starting to look at a potential source for a septic joint.
If they're not febrile, is it okay to not do labs?
Yeah.
Okay.
Yeah.
Would you maybe treat pain and reassess?
Oh, absolutely.
Or get an X-ray, or what are your thoughts?
I think that depends. If sometimes these kids, if they don't feel good and they're really young, they won't walk. So you can figure out a lot about what's going on by just providing a little bit of analgesia. I mean, ideally, you're gonna, if they can and will, you're gonna try to get them to walk beforehand to figure out if you can see at least which side the injury or the infection or the inflammation or whatever it may be is on. But sometimes if they won't walk at all and they're not febrile and they have nothing focal on exam, you might just try a little Tylenol and watch them for a while. If they don't have a good story for any injury, if they don't have really any physical exam abnormalities besides the not walking, I'm probably going to give you some pain medicine and then watch you for a little bit with telling mom, hey, let's work with her or him or the child while you're here. Let's see if we can't get him to walk, and if you can't, try to watch him, and while we're waiting for this Tylenol to kick in, see if you can figure out if he really is favoring one side or the other, if there's some place that does seem to be hurting him. Because we've got a lot of stuff to do. We're going to be room to room, whereas you've got a pretty good source of information with whatever caregiver is with the child to tell you kind of what happens in that interim. Like, oh yeah, so it really seems to be the right foot he won't put down, or he really starting to pick up that left leg more. You really can't get him to do much on that side, and then you can base the rest of your exam and workup and x-rays and whatever else you need to get from there.
So what I'm taking from that is if the kid's doesn't have a fever and doesn't look ill, it's okay to not jump in and do a lot of workup initially.
Yeah.
You could take a more relaxed approach to this. Let's switch gears and say the kid comes in and does have a fever. Let's say it's a 5-year-old male. He won't bear weight on his left leg and he has a fever. What's my workup going to be for that kid?
Yeah, so again, just like everything else, you start with the history and physical, which you got a lot of already, but then I'm gonna be ranging the hip on the side that he's having difficulty with, as well as the knee and the ankle, whatever joint is potentially affected, while also kind of palpating all along the leg for any bony tenderness. With that, from a laboratory standpoint, while I'm trying to find the local source for whatever's going on here, I'm going to be getting some labs to see what else is potentially going on. So when I say labs, if I think that there's a specific joint that's affected, so say if I'm worried about a septic hip in this 5-year-old, he's febrile, but he's not showing real signs of sepsis yet. His heart rate and his blood pressure are stable. He's not having altered mental status. He still looks overall pretty well. You can get labs and wait on those while you're trying to figure out next steps here. The labs that I'm really interested in are basically inflammatory markers and white blood cell count. The reason for that is something called the Kocher criteria, which orthopedic doctors like to use a lot. And I do think it is helpful in a sense. What that is white blood cell count, fever, inability to ambulate, and they use ESR in the original Kocher criteria. If any, as you get more of each of those 4 criteria, your chance of having a septic joint is increased. So they'll quote, I think it's like if you have only one of those things, it's like 3%, which is still, if you're just limping and you don't have a fever, that implies that there's a 3% chance that it's somewhere along the path of a septic joint, right? So none of this is end all be all. Like you could be catching it just that early in the course, right? And that's all that's shown up yet. Whereas if you have 2 of the 4, so fever and limp, you're up to 40%. And then I think that adding 3 and 4 both put you, I think it's 93 and 99 or something like that.
Really high.
Where it's like if you got 3 of the 4, like in my mind, we're at least concerned enough that that's my primary diagnosis at this point.
You're getting admitted.
Yeah, absolutely. Yeah, either with either a tap of the joint or a very soon planned MRI.
Yeah. I mean, it's a tool, a risk stratification tool, right? We love these in the ER. We use these all the time. I feel like I used them a lot more on the adult side than children's, but this is a pediatric specific, not one that I saw outside of the pediatric ER, but we use this all the time for any kind of joint involvement. And so you get those labs, ESR, CRP, white blood count. A blood culture is recommended if you are working up a septic joint as well, and then you calculate your Kocher criteria and you call ortho with that information. So we get the inflammatory markers back. He risk stratifies high. We call ortho. What is this kid's, the rest of his, the sequelae of this is, what is it going to look like for him? Kind of walk us through how that happens in our shop. This may look a little different if you work somewhere else, but where we are, we're in a big facility, so we have lots of resources and we have ortho 24/7. So what does that look like?
Yeah. So once you're to that point, once you have a septic joint as a working diagnosis, you're going to have to make some decisions in conjunction with ortho, and a lot of it's about timing of antibiotic therapy and either tapping the joint to try to get some synovial fluid for a sample, or in lieu of that, trying to get MRI imaging of the affected extremity so that the surgeons can know exactly what they want to get into. So what happens a lot for us is if the kid is clinically stable, but we suspect a septic joint, then a lot of the time that kid gets a stat MRI. Usually happens within hopefully a few hours to at least overnight, while monitoring the kid pretty closely to make sure that we don't have signs of systemic disease. If the kid starts becoming tachycardic, changes in mental status, hypotensive, especially any of these kind of findings of worsening disease, we're either going to go ahead and try to get you to the OR to get tapped or explored if you worry about an osteomyelitis or other local infection. So that's the thing that why I think an MRI is sometimes helpful in these situations if you have a stable kid. And I think that the reason the orthopods do this is because all this Kocher criteria is really good for telling you that something's going on, but none of these is a septic joint test, right? Like, this isn't saying, hey, you have a septic joint, you don't have osteomyelitis, you don't have a pyomyositis, you don't have something else going on in the general area that could be causing inflammation, that could be infectious, but isn't just a joint space infection. So I think having imaging before you go in or just drain the joint without seeing what's going on with the bone is unhelpful, because then that kid's going to have at least 2 anesthesias, right? So one for the MRI and then other for surgery, or at least having the joint aspirated. So I think it's pretty nice that our orthopedic doctors will try to get that all done at once. So they'll MRI and they will be there as it's coming across to see, is this your joint involvement? Is there bone involved? Are we anticipating a washout, or can we just do a joint aspiration? I think it really helps with planning those next steps, all with the caveat of, if this kid's starting to get sick, if this kid's going septic, then all bets are off. I'm gonna give you antibiotics that's gonna try to save your life before we worry about what the underlying bug is.
Right.
I mean, we love to have a specific diagnosis so we can start narrowing things down. But if you're getting that sick, I'm gonna start treating you broadly.
Yeah. And these patients obviously get admitted.
Yeah. Yes.
Different types of things kind of I guess we should talk about our mimics first, and then we'll talk about things that absolutely get admitted. But some mimickers of this that we should remember in our differential. This is an absolutely ginormous list, but just to mention a few things. I'll let you talk about some of these.
Yeah. So I already just was talking about some of these. So everything that looks like a hot joint isn't necessarily just a joint space, right? So all those other kind of localized infections, osteomyelitis, pyomyositis, transient synovitis, and that's the thing that we all hope that this is when you come in with a fever and limp, to kind of put that into perspective. That kid has a fever, has a normal white blood cell count, has normal CRP, ESR. You give him Tylenol or Motrin, and he is walking and back to normal, right? So those are the kids that you can feel a little bit more comfortable with, and say, hey, this is just some synovitis that you're having after you've had a recent URI. You're walking now. Come back if this gets worse. Whereas some of these things, with any of these things with an elevated inflammatory markers in the setting of fever, you're not going anywhere. You're staying here at least for monitoring and for us to decide whether we need to go further. Yeah.
Lots of things here. Any condition that causes generalized inflammation of the body that can cause arthralgia, so endocarditis, HSP.
Yes.
These are all common things we see in kids. Masses anywhere, whether it's a malignancy or a cyst, bone cyst.
Yeah. Another thing in pediatrics, there's a few things that I think that we do a lot of. You already talked about looking at butts. We also have to check genitalia a lot. GU stuff can really kind of masquerade as limp, so it can go up or down. I think of it as, so it can either be a limp or it can just be abdominal pain. So that's why we're always harping on males with lower abdominal pain. You got to make sure that they don't have a torsion, right? So that's one of the mimickers, but it can also present, if you have a testicular pathology, it can present as a limp. So it can kind of be one of those things where you really don't want to miss that in general in some of these kids.
Females too. So I was reading PID can present like this. They have that kind of shuffling gait. When they talked about gaits, I thought it was really cool. What's the gait when you're hunched over? It's called, I've forgotten already.
So there's a Trendelenburg gait, but the most common one that we are going to see is just the classic antalgic gait.
There's in the up to date when they talk about the evaluation of a limping child, they talk about all these different gaits, which I think is really cool. You were mentioning this antalgic gait, which is the one that we see where you're kind of hurting and you don't want it, so you're moving really quickly on that side that hurts. But stooping gait. So I thought this was really interesting. Because I had a kid I was working up for appendicitis, and I thought, everything kind of looked okay, and I was working with Whitney, and she said, "Have you ambulated the patient?" And I said, "No, I haven't gotten her out of the bed." And she said, "Go get her out of the bed. Let's go look at her walk." And what do you know? The patient could not straighten up. She couldn't stand all the way up. Because she had inflammation or irritation in her belly that kept her from standing up completely. And I thought it was interesting that I hadn't really thought of looking at that for an exam, but they mentioned that here as something that you should think about abdominal pathology in particular, because it may be an indication that there's inflammation around those lower pelvic muscles. So anyway, interesting on the differential. All right, we also have, so we talked about female, male, GU pathology, things to not forget when you're looking at this. Epidural abscess.
Yeah, so neurologic stuff is also a mimicker of or is a cause of limp in children. A lot of times this is going to be bilateral, depending on what it is. You often see these kind of ascending paralysis, Guillain-Barré, that kind of stuff. So not only is your walking the kids important, some of them, especially if you're having bilateral symptoms, you don't really have another good source. I think checking reflexes is a huge thing, and it's really easy to kind of forget about if you're trying to do a quick exam, trying to just, quote unquote, get the patient to walk, right? Or just trying to get to the bottom of this limp whenever there could be something a little bit more insidious going on.
Yeah.
That's not directly obvious. That's why, you're not completely out of the woods when you completely range a kid and they have no focal tenderness and no obvious hot joint or joint involvement. You can, in some ways, feel better about things, but it changes what you worry about instead of just makes you not worry in general,
Right. Is their gait just kind of weird, and this is something neuromuscular?
Yeah, if you're walking at all, or are you getting more tired, or what is your gait pattern if you can walk? Another thing that we see in pediatrics are kids with sickle cell. We see a lot of those kids. The one of the classic board questions and questions that we get along the way are what are the common bugs for stuff like this in sickle cell patients, and at least for osteomyelitis and other things that are going to give you focal infections in these kids. Salmonella is a more common cause. It's still not as prevalent as MRSA. MRSA is still your most common bug for these kids, but they are more predisposed to salmonella. So that's something to think about whenever you're seeing a kid with a limp, especially in a setting of sickle cell. Just makes you wonder what is going on, and when you do get to the bottom of it, I really want to give you antibiotics, but I really want to make sure that we have a good culture first, if we can, to try to get to the bottom of it and make sure we're not missing something.
Mm-hmm, mm-hmm. All right. Well, I think we covered a lot of these. All right. In a perfect world, if the world were your oyster and a consultant, or not a consultant, I'm sorry, if the world were your oyster and you could have anybody that calls and wants to transfer a kid with a condition like this to us, or they're in a clinic or whatever the setting may be, what do you kind of think a provider in another ED, what can they do first before they call us, rather than calling with just a limp? I think this is a septic joint. What can they do at that outside facility before they call us? What would you like to hear?
Yeah, absolutely. I think that a reasonable way to break that down is, if you're getting a call from an outside hospital, if they're concerned for limp and fever and thereby have some concern in their mind for a septic joint, I would like to see some inflammatory markers and some labs, and at least draw a blood culture. It's one of those things where this kid may get sicker while they're with you, and you may find yourself in a situation where you're really needing to get antibiotics. So if you have that blood culture already done at that point, we can feel a little bit better about at least having that. I don't necessarily expect you to tap the joint out there or to go ahead and give antibiotics actually, for that exact reason of trying to get to the bottom of the source. If the kid's stable, I'd prefer that you not give antibiotics off the jump, but at least have some labs to try to figure out where we are here. Because the other part of that is if the kid comes in with a fever and a limp and is in that kind of range for transient synovitis, and while they're there, their inflammatory markers come back perfect, and the kid now running around the ER, do they need to be transferred? Right. So that's something that can be really kind of helpful and save some waste on that end of things.
Yeah, give them some analgesics.
Yeah, exactly. So there are a few things that can definitely be done before coming here, but at the end of the day, like if you're worried enough about the kid, or especially if it's a kid that won't walk, even if their fever resolves or wasn't there in the first place, if you got a kid that won't walk, I'm going to take them. We're going to see what's going on with them. Do
you ever send them home if they can't walk?
Not in my experience.
Yeah.
I haven't ever, unless I guess technically if you have a fracture and I put you in a long leg cast, right? But if you should be walking and you're not, you're staying until you walk.
Yeah. Yeah, so you work them up, their inflammatory markers are normal. We gave them Motrin.
Yeah.
They still won't walk.
Walking. I'm going to meet you overnight.
You're going to stay with us.
Yeah, exactly. Yeah. Further eval, serial exams, whatever else is needed.
Yeah. So have you had any horrible cases with regard to this? Have you had any really, decompensated and went bad on you?
I haven't had, I've been lucky enough to not have any that started off okay from a septic joint standpoint and then went truly septic. I have had a few kids with site-specific, what ends up being a septic joint in conjunction with an underlying osteo, and those can be pretty bad. Those are already kind of eating away at bone. I had one that was primarily a tibial osteo is what it turned out to be whenever I was concerned about the knee. But it can be, even with that, the scariest thing to me is that it can sometimes be subtle. And like I said, I think it all depends on where you're seeing them in the process. That's why I have such a low threshold to test these. That's why it's just if you got a fever and you are limping, you are getting tested, because you could be very early in this process and really not very sick yet, but heading that way quickly. And that's what worries me is the kids, if he does great and you defervesce and you walk and you feel okay with it, okay, I'm going to let you go home. I'm still going to be talking to your caregivers about what to watch for, and you bring him back quick if this gets to the point where he won't walk again and it's getting worse and he's hurting more and more, fevers won't come down, that kind of stuff.
Yeah.
So really pretty strict return precautions for anybody if I do let you go home.
Yeah, I had that one case when I saw the kid. He looked fantastic. His complaint was knee pain. I think he was 10. Came from an outside hospital with he left AMA, came to our facility. So I didn't have any records, but mom's they told me he's septic. The kid looks awesome. He won't walk on the extremity, but he looked great and he was stable. So I was you're not septic. But he was, and his labs were terrible. And when I left, he was still stable, but by morning, as he waited in the ER and we were boarding him, ended up in toxic shock and in the ICU and had a pretty rough outcome. So definitely have seen them decompensate right before our very eyes in a short period of time with a kid that didn't walk in, but came into the ER looking like a healthy kid. So certainly have seen a little bit of scariness in this department. So I love to talk about scripting. I think it's part of the art of taking care of pediatric patients. It's the part I think we all take the most time to develop very well. And I love to give suggestions to people on how to script well, because, we really have to put confidence in the parents that come in. They have to feel that we know what we're talking about and we can explain it well to them. How do you talk to a parent of a kid that has a septic joint? How do you explain that? What do you tell them caused this? Did I do something wrong? The things you hear from parents. Tell me what your scripting looks like for a parent.
Sure. I think that the first thing is going to depend on what the underlying cause. If we think that this is truly just a hematogenous spread, we don't have an obvious source, there's no, animal bite right over it or no skin break, doesn't have any underlying reason to have this, then I'm just going to talk about how this is just bad luck, basically. This is just what happens when you get unlucky and bacteria gets where it shouldn't be and sets up there. And so that's how I start describing it. Then I a lot of times start talking to them about why we're seeing what we're seeing, like why is this causing this pain. I do talk a lot about how they'll want to hold their legs in a certain way to increase the space of that joint cavity to really open it up as it's starting to get filled with all that kind of gross pus to give themselves the most relief. And then I start talking about how, this is a serious thing. Kids can have lifelong issues with the affected joints if we don't get to it early enough. So yes, in the ER, we are watching to make sure that they aren't going to collapse from overwhelming systemic infection, but also even if you just keep it local and you don't get it treated within those first few days, you can have your joint destroyed, and you're going to have long-term sequelae from this. So I don't try to scare these parents, but I do kind of make sure that they understand the seriousness of this infection. Like, usually not life-threatening, but could be limb-threatening or at least limb-debilitating for long-term if we don't get into it in time and treat this with the respect that it deserves.
Yeah, please don't leave.
Yes, please don't leave.
Please keep your child in the hospital with us. All right, that's great. Any specific pitfalls and pearls, things that, we need not remember? What are the kind of highlights for this topic?
Yeah. So a few things, especially trying to keep this pediatric specific. I already talked about, my big thing, fever and limp. That's red flag number one. Like, you're getting treated like you have a septic joint until proven otherwise. I think really thinking about some of those look-alike, sound-alikes. So if you have really doing a good GU exam on pediatric patients, really doing a full exam, looking at the skin, got to disrobe them if need be, and really those kind of tricks to get the patient to walk. Like take them away from mom, and if they can, most of the time they're gonna walk back, and so that's usually your best bet to get a really young child of walking age to walk.
Yeah, I like that. Or Bluey helps too.
Oh, what doesn't Bluey help?
I love it. All right, and we admit kids that won't walk. I think the big take home for me when I switched to pediatrics was kids that don't use extremities is never normal. That's not normal, and we take that pretty seriously, trying to figure out what's going on. So
absolutely.
Okay, awesome. Can you think of anything else we didn't cover?
Wait till 5 minutes after we're done. I'm sure it's
1,000 things we didn't cover. Thank you for joining us here today at PEM Chat. I hope you enjoyed today's episode. Please join us next time when I'll be talking with Kaylee Mounts, nurse practitioner, and we're going to be discussing one of the most common things we see in the pediatric emergency setting, and that's the febrile seizure. I hope to see you then. Any opinions expressed on today's podcast are solely those of the speaker and do not reflect the opinions or policies of any employer or hospital system. In many states, advanced practice providers work collaboratively with physicians. One should always be careful to consult with your physician leader when it's appropriate. This podcast was designed for medical education purposes only. Its speakers have made every effort to provide the most current and evidence-based information. However, that should never replace one's own effort to validate current evidence-based practice before implementing a plan of care. Any pathway or algorithm that we may have discussed may not reflect those of your healthcare system. Please be aware that these may change based on your geographic location or current employer site. This podcast was not designed in any way to provide medical advice or treatment plans for patients and their families. If you have a medical concern or an emergency, please be seen by a local medical provider or call 911 for assistance. All right. Well, I appreciate you coming on today. It was a pleasure having you. I will be hitting you up for another topic for sure.
Of course.
All right. Well, I appreciate you, and thanks for coming.
Thanks so much, Ty.
All right. Bye.